Review of the renin angiotensin aldosterone mechanism. So what exactly is this renin angiotensin aldosterone me mechanism? Right. So as the name itself indicates, there are several players over here that are going to regulate your blood volume, and those that are going to regulate your blood pressure. So out of them, the first one that you're going to study is the renin, and then the second is your angiotensin, then the aldosterone, and there are several other organs in the body that are also involved with the renin angiotensin aldosterone mechanism. Or you can also call this as the renin angiotensin aldosterone system or the renin angiotensin aldosterone axis. So, before we begin this particular concept, we have to just write up a small story. So imagine there is a person, all right, and he has encountered a trauma, maybe a car accident or somebody stabbed him in the abdomen, all right. So whatever the case might be, that person has got trauma and there is internal injury, and his blood levels or the blood volume is falling down. As the blood level is falling down, there will be decrease in the blood pressure. Now, when this situation happens, because of this particular mechanism or machinery, what happens is the body tries to maintain the homeostasis of the body, which is called as the myelo-interior from your first year physiology. So basic concept of this mechanism is to revert the changes that were there before the trauma occurred. So how does the body deals with it is going to be your entire class. So what you have to do is, first you have to draw your general circulation. So general circulation can be denoted by this. So imagine this is your general circulation. All right. Now at the heart of the general circulation is your organ, which is your heart. So at the heart of general circulation is your heart. Now, you know from your first year physiology that the cardiac output of the heart is, that means the amount of blood that is pumped by the heart every minute is 5 liters per minute. To be precise, it is 70 into 70, 4,900 ml per minute, right? All right. So out of this, for organ perfusion, some amount of blood goes to the brain, some amount goes to the lungs, some amount goes to the liver, some amount to the kidneys, and to the peripheral organs of the body. Now, the first player that is involved in the renin angiotensin aldosterone mechanism is your kidney. All right. When we talk about kidney, we are actually talking about the functional unit of the kidney, which is your nephron. All right. So when we talk about nephron, let's talk about the anatomy of the nephron first. So unit-wise, there are about 1.2 million nephrons in each kidney. So any human body on an average will have 2.4 to 2.5 million nephrons. All right. If you are taking high-level antibiotics or you are taking cephalosporins, they have the capacity to destroy your nephrons. Particularly, you'll be reading in the coming classes in antibacterials that there is a drug called cefotaxime that is capable of destroying 2 nephrons when taken in a dose, when taken in a daily dose for a 3-day schedule. All right. So many of the textbooks don't give this point, but since you are studying the subject of pharmacology, you have to know that minutely what these drugs actually do. So some of the drugs that you take have the capacity to destroy the nephrons. All right. So now what we'll do is we'll study the anatomy of the nephrons with respect to the renin angiotensin aldosterone mechanism. So let us draw the nephron. So imagine this is your proximal convoluted tubule. All right, this is a descending loop of Henle, the descending link, of loop of Henle, the loop of Henle, then this is the ascending limb of loop of Henle, and this is your distal convoluted tubule. All right, and as the nephron finishes, it becomes your collecting duct. All right. Now this is your rough picture of the nephron of the kidney. All right. So can you just tell me what are the parts? What is this?
Bowman's capsule.
This is your Bowman's capsule. This is your Bowman's capsule. Then this is your
PCT, proximal convoluted.
proximal convoluted tubule, and this is your descending
Limb of loop of Henle.
loop of Henle. This is your loop of Henle. This is the ascending limb of loop of Henle.
Of Henle.
This is actually supposed to be broader, all right, but due to lack of space, I've just drawn it. Then this is your distal convoluted tubule, and this is your collecting duct. All right. So we have studied the parts of the nephron. Now let us take a look as to how the nephron interacts with the renin angiotensin aldosterone mechanism. All right. Now let us come back to the physiology now. Now, every minute 5 liters of cardiac output is being pumped by the heart. Out of the 5 liters, about 20% of the cardiac output goes to the kidney. So how much is 20% of 5 liters? 20% of 5 liters becomes how much?
1 liter.
1 liter. So, so through the renal artery, the 1 liter of blood is being pumped to the kidney every minute. All right. So what we'll do is we'll draw the renal artery now. Renal artery as in you will draw the efferent arteriole. So from the general circulation, there is renal artery coming in, and basically what we are drawing the efferent arteriole. All right. And here it forms a network, a plexus kind of thing, which we call it the Bowman's, which we call it the glomerulus, where all the organic solutes are reabsorbed or secreted depending on the usage. And then this efferent arteriole continues as the efferent arteriole, right? Sorry, efferent arteriole, and
Macula densa. DCT.
so this is your, sorry. So this was your efferent arteriole, A dot A. Then this is your efferent arteriole, E dot A. Now this efferent arteriole, what happens is it near the tubules, that is the proximal convoluted tubule and the descending limb of loop of Henle. What happens is it forms a peritubular network. Right, like this. It forms a peritubular network, and then what happens? It continues as the renal vein. So through long processes, it's again comes back to the general circulation. It goes to the heart, it combines with the inferior vena cava, and it is sent to the heart. So this blue line that you're seeing is your deoxygenated blood, and this is your renal vein. So renal artery we have divided into efferent arteriole and efferent arteriole. So about every minute from 5 liters, 1 liter of blood goes to the kidney. All right. So 1 liter of blood every minute. Now in this 1 liter of blood, what happens is 600 ml of blood flows through the efferent and the efferent arteriole every minute, and the rest of the 400 goes to the extracellular spaces. All right. Now after out of this 600 per minute, what happens is every minute there is certain amount of filtrate that is either reabsorbed or secreted into the lumen of the nephron. So out of the 600, if we take the 10% of 600, how much does it become?
600.
10% of 600 is how much?
60 ml.
60 ml per minute. How much is 20% of 600 ml?
20%.
120.
120.
120 ml. So this 120 ml that you have got in combination with 20% of the 600 is actually your glomerular filtration rate. So this is how you get your 120 ml per minute. This is just not a random number. It is through simple mathematics. All right. So your cardiac output was 5 liters per minute, out of which 20% goes to the kidney. This 1 liter is split into 600 ml and 400 ml. 400 ml goes to the extracellular spaces and the cellular, whatever we have surrounding the nephron. 600 ml goes through the efferent arterioles, out of which 20% is reabsorbed. It goes through the lumens, and that is what your glomerular filtration rate is. That is the rate at which the filtrates are getting reabsorbed or secreted. All right. So now, since we are talking about a traumatic injury being happening to this patient right now, what happens is, just hold on for a second. Give me a minute. All right, let us continue. So out of that 600 ml, 20% goes through the filtrate, and that becomes your GFR. So the body is used to having 1 liter per minute, 1 liters of blood every minute, 600 ml through the efferent arteriole, and 120 ml per minute for the GFR. So this is the normal physiology. Now, when there is a traumatic injury, what happens? Okay, so when there is a traumatic injury, it's quite obvious that there is internal injury and the blood is leaking out. So this defines that your blood is leaking out. All right. So what do you think will happen to the blood volume? Does it increase or decrease? Or remain same?
Decrease.
It will decrease. Then what happens to your blood pressure? Does it increase, decrease, or remain same?
Decrease.
It will decrease. All right. So do you think in this situation, even if the heart pumps 20% of the blood to the kidney, do you think 1 liter of per minute reaches the kidney? No. Do you think 600 ml per minute reaches the efferent arteriole? No. Do you think 120 ml per minute will be your GFR? No. It will all get decreased. All right. Now, the reason why I'm telling you this is, now as there are hemodynamic changes occurring, there should be something that should happen and should stimulate the renin angiotensin aldosterone mechanism. So this decrease in the BP and the decrease in the blood volume is the main factor that will stimulate the renin angiotensin aldosterone mechanism, and that will kick in the first player, that is your renin. All right. So let us take a look as to from where the renin is being produced. All right. So what I'll do is I'll just redraw this again. All right. Now, if you take a look at the efferent arteriole basically has got smooth muscles, right? Every arteriole or every artery will have smooth muscles. Now this efferent arteriole, as it is nearing the proximal convoluted tubule and the distal convoluted tubule, the smooth muscles of the efferent arterioles, they get reorganized into special types of modified smooth muscle cells. All right. So they won't be your typical smooth muscles. They will get reorganized and they will form certain types of modified smooth muscle cells that will be arranged erratically like this. Right. So these modified smooth muscle cells that arise from the efferent arterioles, these are termed as Bronchus cells. All right. Now, after we have drawn the Bronchus cells, what happens is there is something, all right, there is interconnecting connective tissue, all right. This is the interconnecting connective tissue. This interconnecting connective tissue connects it to a group of cells that I would like to call that are present on the distal convoluted tubule, starting of the distal convoluted tubule, and they look like tall dark patches. They look like tall dark patches. So when these cells were first looked under a microscope, and when the histology of a nephron was first studied, and they were looked under a microscope, they looked like tall dark patches under the microscope, and tall dark dense patches under the microscope, and hence they were referred to as macula densa. Now, why am I talking about this? The reason I'm talking about this is because when you connect the Pulcosyn cells, the connective tissue, and the macula densa together, they together form a unit which is referred to as juxtaglomerular apparatus. Juxta means adjoining to the glomerulus. This is your glomerulus. So they are adjacent to the glomerulus, and since they are a one unit, they are referred to as apparatus. So this is nothing but your juxtaglomerular apparatus. That is a combination of Pulcosyn cells and macula densa. Now, this Pulcosyn cell is nothing but a baroreceptor. That means it will sense changes in the blood pressure. So now these Pulcosyn cells, they are under routine sensing changes in the blood pressure. That means under normal physiology, they always feel 600 ml of blood flowing above them. 600 ml on day 1, 600 ml on day 2, 600 ml on day 3, till the entire life of that person is over. But when there is certain trauma occurring, do you think 600 ml will be flowing through the efferent arteriole? No. 600 ml won't be flowing. It should be decreased, and it should be either around 400 ml, 350 ml, depending upon the severity of the trauma. So when the Pulcosyn cells, they feel that there is something abnormal with the blood pressure, what they do is they cause the release of your first player in the renin angiotensin aldosterone mechanism, which is your renin. So renin is released from the Pulcosyn cells. All right. Now this renin, it flows through the efferent arteriole, it goes to the efferent arteriole through the peritubular network, through the renal vein, and it enters the general circulation. All right. Now this is what happens. Now, imagine that the blood is passing, and as usual, the normal physiology is also occurring, and the solutes are getting filtered or secreted or reabsorbed, depending upon the solute. Now, do you think? No, okay. Before that, what is the major solute that is being reabsorbed under normal physiology? The major
Sodium.
ion, yes, the major ion that is reabsorbed under normal physiology is your sodium. Now, maximum reabsorption of sodium occurs in the proximal collimated tubules. That is around 75 to 80% or maybe more is reabsorbed through in the proximal collimated tubule. Now, when the GFR decreases, you think more of sodium will be reabsorbed or less of sodium will be reabsorbed? My question
More of
is,
sodium.
will more amount of sodium gets reabsorbed or less amounts of sodium gets reabsorbed?
Sir, can you repeat the topic? Question regarding this?
At glomerular filtration rate of 120 ml per minute, there is sodium reabsorption of at the rate of 75 to 80%. So when my GFR falls down to 100 or let's say 90 ml per minute, do you think more amount of sodium gets reabsorbed or less amount of sodium gets reabsorbed?
It is not under the action of renin, right?
No, this is a
Aldosterone.
simple question. Your answer should be limited to more or less. So Furkan, can you tell
Less.
me more amount of sodium gets reabsorbed or less amount of sodium gets reabsorbed? Okay, I'll give you a small example. All right, this is a waterfall. All right, this is a waterfall, and what happens is at 5 kilometers per hour or 5 kilometers per minute, apples are falling. All right, and what you're doing is you are standing near the edge of this waterfall and you're collecting apples. All right, now at the rate of 5 kilometers per minute, you are able to collect, let's say, 2 apples. All right, now what I do is I reduce the speed of this water current. I decrease it to 1 kilometer per minute. So at this rate, are you able to collect more apples or less apples?
Less apples,
More
obviously.
apples.
Now the water current has decreased. That means you will be able to collect more apples,
More apples.
right? So in the same way, when this happens, during traumatic injury, the GFR decreases. So instead of the proximal convoluted tubule reabsorbing 75% of sodium, it will reabsorb more than 80%. All right. So the more than 80% of sodium is getting reabsorbed over here. All right. Now, as this sodium, the leftover sodium that has not been reabsorbed, it comes over here. It travels the distal convoluted tubule. It has to undergo through the beneath the macula densa. Now, these macula densa are your chemoreceptors. They like to have the taste of sodium. Now, under normal physiology, around 10 to 20% of sodium gets reabsorbed in the distal convoluted tubule. But since more amount of sodium is getting reabsorbed in the proximal convoluted tubule, less amount of sodium reaches the distal convoluted tubule. So the macula densa, they think, I was just a day before I was sensing, around 10 to 20% of sodium. Now I'm not even getting 5%. What is the problem? Is there any has the person gone into any kinds of shock or some pathology or some accident? What is happening? So what it does is, with the help of some local prostaglandins, it will stimulate, the macula densa will stimulate the Pulcosyn cells to further augment the release of renin. So more amount of renin gets produced from the Pulcosyn cells with the help of macula densa. Now this renin will again eventually go into the renal. So this is how your nephron basically controls the regulation of renin. That is through the help of juxtaglomerular apparatus. It helps the use of Pulcosyn and your macula densa. Pulcosyn is your baroreceptor, while macula densa is your chemoreceptor. All right. Now when this renin has reached your general circulation, what happens? Now, when this renin enters your general circulation, there is a second player that comes into your picture, and that is your liver. So we'll draw the liver over here. All right. So this is the liver, and it contains hepatocytes. All right. And liver is the site of production of all the proteins. All right, globulins, albumins, except which globulin? It forms alpha, beta.
Globulin.
Gamma.
Yes, gamma globulin is not formed in the liver because gamma globulin is actually your
IgG
antibody.
antibodies.
Right. So antibodies are not produced in the liver. So this liver, it produces one particular protein which is called as angiotensinogen. Right. This renin, it acts on the angiotensinogen and it converts it into a compound which is called as angiotensin 1. Right. So this is the angiotensin 1 that is formed now. Now, after angiotensin is 1, this angiotensin 1 undergoes the test of its potency. All right, that means it undergoes basically what do you call that? Agni Pariksha. All right. So let us draw the other player that comes into the picture, and that will be your lung. Right. So this is your lung. All right. Lung with its bronchopulmonary segments, right? This is your lung, basically. So now, after, okay, I'll just remove this heart. Right. Now, what happens is when this angiotensin 1 flows through the lung, and when it comes out, it becomes angiotensin 2. Right. That means inside the lung, there is something that is capable of converting angiotensin 1 into angiotensin 2. That's something we call it as angiotensin converting enzyme. That is present in the endothelial bed of the lungs. All right, this is an important PG question that was asked. Angiotensin converting enzyme is located in the dash. A, B, C, D options were there. The correct option is the endothelium of the lung. All right. Now, this is the angiotensin converting enzyme, and when AT1 travels through the angiotensin converting enzyme, when it comes out, it becomes your angiotensin converting angiotensin 2. Now, this angiotensin 2 is a powerful vasoconstrictor. All right. Now, apart from ACE converting AT1 to AT2, it does one more thing. And what it does is there is a local vasodilator by the name bradykinin. All right. Bradykinin is a local vasodilator. Now, since the BP is already going down, we don't want any vasodilators to be acting in the periphery or in the center. So what this ACE does is it will metabolize bradykinin, so that there is no vasodilatory effect of the bradykinin. All right. Now we have, if you remember, we have got a group of antihypertensives which are referred to as ACE inhibitors. All right. ACE inhibitors, the most important side effect of ACE inhibitors is that it produces cough. The cough is so horrible that the compliance of the patient is very less. So the patient discontinues the ACE inhibitors. All right. Now this cough is produced why? Because when you take angiotensin converting enzyme inhibitors to decrease the BP, it will obviously not metabolize bradykinin. All right. This bradykinin will go and act on its receptors, which are called as BR receptors. All right. And whenever BR receptors which are present on the bronchus are stimulated, it results in bronchospasm. That spasm, it stimulates cough. So that cough is it's so ugly that the patient is just discontinues the angiotensin converting enzyme inhibitor therapy. So that is one thing that you have to remember. Okay. So moving on, we have got a very powerful vasoconstrictor, and that is your angiotensin 2. Now, where does this angiotensin act? This angiotensin will act on the heart, which is another big player in your RAA mechanism. Now, what happens is, let us draw the heart and then you will understand. So, this is your right auricle, all right? And then it is joined by the superior vena cava from above and inferior vena cava from below, all right? And then this is your right ventricle. Okay. Now this right ventricle has got opening of the pulmonary artery, right? So this is your right auricle, this is your right ventricle, and this is the opening, and this is the pulmonary trunk. All right, dividing into right and left. Now, what happens next is you have to draw the left side of the heart. So the left side of the heart is mainly constituted by the left ventricle. So first we'll draw a small left auricle. All right. This left auricle will receive the pulmonary trunk, right? And then you have to continue drawing your left ventricle. This left ventricle, and from the left ventricle, what comes out? Your systemic aorta, right? So this is your systemic aorta. Let me draw. So this is your systemic aorta. Right. Now, this is your left auricle and this is your left ventricle. Left ventricle occupies majority of the space. It is a highly muscular organ. All right. Now, so this is the pulmonary trunk and the left auricle receiving the blood supply. Now, what happens is, what I'm going to talk about is the action of angiotensin II. All right. Now, the pulmonary circuit and the systemic circuit, you know from your normal physiology that they have a connection. They make a connection. So what are we going to do next is we are going to make connections between the pulmonary circuit and the systemic circuit. Now, after having made the connections between the pulmonary circuit and the systemic circuit, what are we going to do next is we are going to draw the receptors for angiotensin II. So this is basically the venous side. This is basically the arterial side. All right. So now after having drawn the receptors, what happens is this 82, which we have drawn in red color, will come and bind to its receptors, both on the pulmonary circuit and both on the systemic circuit. All right. Now, when angiotensin or any other drug or toxin or any neurotransmitter, when it goes and binds to its receptor, it causes stimulation of the receptors. Now, when these particular receptors are stimulated, what happens is they cause constriction of the arterioles and the venules. So they cause constriction of the arterioles, the venules and also the arterioles. So now let us go into the cardiac cycle or the cardiac physiology. What happens when the venules are, when the smooth muscles of the venules are constricted? So let me write it down over here. When the venous smooth muscles are stimulated, what happens is there will be
Total peripheral resistance.
constriction of the veins. Now when the veins constrict, what happens? There will be increase in the preload. When the preload increases, there will be, so what happens is there is increase in the preload. All right, blood is reaching the right auricle, it is reaching the right ventricle, it is going through the pulmonary circuit, and it is coming to the left auricle. So what happens is blood flow to the left side of the heart is also increasing. Left heart blood increases. So when the blood flow to the left heart increases, what happens to the cardiac filling? There will be more of cardiac filling. And from your normal physiology, you know that Frank's law told me that when there is more of cardiac filling, there is extension of the left ventricle. And when the left ventricle extends, it will contract the same. So when there is more of cardiac filling, according to Frank-Starling's law, we told that it will cause increase in the stroke volume, that will cause increase in the cardiac output, and that will result in increase in the systolic blood pressure. So we have increased the cardiac filling, we have increased the stroke volume, all right, and here we have increased the cardiac output through the systemic aorta, right? So this is what happens when angiotensin II is acting on the pulmonary circuit. Now, let us talk about after the heart has undergone contraction. The next step that the heart does it undergoes into diastole mode. That means it goes into relaxation mode. So AT2 now goes and acts on the AT2 receptors on the systemic circuit. Now, when the systemic circuit or when the receptors of the AT2 on the systemic circuit are stimulated, what happens is there will be arteriolar smooth muscle contraction, and since the heart is in a diastole mode, it undergoes relaxation. And when it undergoes relaxation, the valves of the left ventricle are closed, right? So if the blood is in the systemic aorta, it cannot go back, right? Because the valve is closed. So the blood has to remain in the systemic aorta itself. So when the blood remains in the systemic aorta, during the diastole period, it causes result in the increase in the blood pressure. And since it is happening in the diastole period, we cause increase in the diastolic blood pressure. So there is no way that the blood can go back or can go through the arterioles, because these are constricted, these have become very narrow, so the blood cannot escape from here, right? And it cannot go back also. So the blood remains in the systemic aorta during the diastole period. And you know from your normal physiology, the definition of blood pressure is the pressure exerted by a column of blood on the lateral walls of the blood pressure, or on the blood vessel. So what is the blood vessel we are talking about? The blood vessel that we are talking about is the systemic aorta. So the pressure exerted by the blood in the systemic aorta during diastole is referred to as diastolic blood pressure. And when that happens, we cause increase in the diastolic blood pressure also. So what have we done now? We have made an increase in the systemic blood pressure as well as diastolic blood pressure. That is what we wanted to do from the start. All right. So any questions or any doubts that you have till here? All right. So what we'll do is we'll talk about and introduce another player that we have in our chapter. So what I'll do is I'll just clear out these things. All right. And I will introduce you to another player of our study, which we refer to as the adrenal gland. So we have got adrenal gland or the suprarenal gland that sits on the top of the kidney. Now, to be very precise, I'll be talking about the zona glomerulosa. So this zona glomerulosa, what it has is it has got a chemical which we call it as aldosterone. Now, this aldosterone, what it does is it is very unique, all right, because it acts on specific site of the nephron. So I'll just redraw. Right. I'll just redraw the nephron again. So this I have told you as the distal convoluted tubule, and okay, I'll just shorten the nephron. Now on the distal convoluted tubule, you have what we call a cell which is named as P cell or principal cell. Now this P cells contains three sets of genes inside. This is one gene, this second gene, and the third gene. Now this P cell also contains an intracellular receptor, and that receptor is for your aldosterone. So you have got a receptor, right? And this is the receptor on which your aldosterone will come and bind. Now, when aldosterone comes and binds on this particular receptor, what happens is it will activate these 1, 2, and 3 genes. Now, when there is activation of the first gene, what happens is there will be formation of sodium potassium ATPase pumps on the basolateral membranes. So when there is activation of the first gene, it will result in the formation of sodium potassium ATPase pumps. So what will these pumps do? They will kick 3 sodium out and they will take 2 potassiums inside. Right. So now, what do I mean by kicking 3 sodiums out? What I mean by kicking 3 sodiums out is that this sodium will now get reabsorbed and enter the general circulation. Now there is a fundamental rule, a basic rule, that wherever sodium goes, water will follow. So when sodium is going into the general circulation, automatically water also follows the sodium. So when water enters the general circulation, what happens to your blood volume? Blood volume will automatically gets increased. So that is what we wanted. So through the angiotensin II, we have increased the blood pressure, and through the aldosterone, we have caused increase in the sodium potassium ATPase pumps on the P cells of the distal convoluted tubule, and we have caused reabsorption of sodium. And wherever sodium goes, water follows, and that increases your blood volume. Now, when you activate this second gene, what happens is it will result in the opening of or formation of sodium channels. This sodium channels will again take up more amount of sodium inside. And as sodium comes inside, this sodium again through the sodium potassium ATPase pumps is kicked out. And when it is kicked out, water will follow and it will result in increase in the more amount of blood volume. Now, this third gene, what happens is this third gene will cause opening up of potassium channels. And since the potassium that is coming through the sodium potassium ATPase pumps will get excreted. All right. So this is about the aldosterone. Now, the main and the most important player of the renin angiotensin aldosterone mechanism is your central nervous system. So now, what does your central nervous system do? So let us first draw the central nervous system. So this is your central nervous system, all right? This is your brain and the spinal cord, and you know that it has got anterior pituitary and the posterior pituitary, right? All right. So let us first talk about the posterior pituitary. Before we talk about the posterior pituitary, near the heart, we know that there is something called as the baroreceptor, the carotid body, right, or the carotid sinus. Now that carotid sinus is the main baroreceptor of the body that senses the changes in the systemic blood pressure. Now when all this mechanism is happening, this carotid body or the carotid sinus, what it does is it sends impulses through its nerves and causes activation of the sympathetic autonomic nervous system. Sympathetic autonomic nervous system is your thoracolumbar outflow. So you have got thoracolumbar outflow, the preganglionic nerves coming from your thoracolumbar outflow. They result in the formation of a ganglion, right? And from the ganglion, what happens is another set of postganglionic neuron arises, and this postganglionic neuron will all the way again travel to your Purkinje cells, because the Purkinje cells will have got your beta receptors. So just go back to your autonomic nervous system and remember that
One
beta 1
receptors are
receptors,
present on kidney.
yes, beta 1 receptors on stimulation will cause increase in the renin, and now you know why, right? So Purkinje cells will have got beta 1 receptors, and when there is a changes in the blood pressure, the carotid body will send impulses to the sympathetic autonomic nervous system, and this sympathetic autonomic nervous system through their postganglionic neurons will cause activation of the Purkinje cells, in turn will cause activation of the beta receptors, that will cause increase in the renin. Renin will now enter the general circulation. All right, so this is the autonomic nervous system that we dealt in the previous classes. Now we are picturizing it. All right, now after having talked about the sympathetic autonomic nervous system, let us also include another thing that we have studied, that through the preganglionic and the postganglionic, it also causes the release of norepinephrine. which acts on the alpha receptors, causing increase in the BP. Right. So this is the two-way mechanism by which sympathetic autonomic nervous system or the thoracolumbar outflow will cause increase in the blood pressure, and that is what we wanted. Right. Now, after having learned this, let us go back to the brain. Now, the brain has got what? It has got anterior pituitary and posterior pituitary. Now, this posterior pituitary will have got a hormone called as oxytocin and antidiuretic hormone or vasopressin. Now, this antidiuretic hormone, when the patient is under normal physiology, it doesn't come into effect. All right. But when the body feels or the CNS feels that there is less of blood volume and it has to increase the blood volume, what it does is it acts on the specific part of the convoluted or the collecting duct. This is the part of the collecting duct on which your aldus or your antidiuretic hormone works. All right. So antidiuresis, that means it will not allow the diuresis of water or the expulsion of water or the release of water in the form of urine. So what will it do? It will make this particular part of the convoluted tubule water leaky. That means this hypoosmolar, it will make this lumen hypoosmolar, and since it makes it hypoosmolar and the outside is hyperosmolar, the water is pushed outside, and when it is pushed outside, it enters the peritubular network, the vasa recta, and it goes into the general circulation, thereby increasing the blood volume. So that is how your antidiuresis, anti-water excreting hormone comes into the picture. When it feels that the body requires more amount of water, it will make this particular part of the collecting duct water leaky, and when the body is under normal physiology, this will become watertight junction. That means water gets excreted under normal physiology. When it is under pathology, some kind of trauma has happened, this region becomes water leaky. That means the water is reabsorbed. The lumen becomes hypoosmolar, so water goes from hypoosmolar state to water hyperosmolar state. Right. The last thing in this particular slide that we have to understand is that hypothalamus in the brain has got a thirst center. All right. And when a patient is in acute need of water, what happens is this thirst center gets activated. And when the thirst center gets activated, the patient, he asks you for a glass of water. And when he has that glass of water, he quenches his thirst, thereby increasing the blood volume again. So this is all about the renin angiotensin aldosterone mechanism.